local groups run by voluntary services. And also I was interested in the role of mental health services. So I used a broad definition of self-harm. I included intentional self-poisoning, so with medications or with other substances, as well as self-injury. And this is because it's not always easy to determine suicidal intent, and people often use more than one method of self-harm during an episode of self-harm. It's a common reason for hospital presentation, although many more episodes of self-harm are only visible to health services. In addition, people commonly seek help from their GP or from non-healthcare settings, such as we mentioned before, self-help, peer support groups. But people who present to the ED following self-harm have around about a 50-fold increased risk of suicide compared to the general population. Risk is similarly increased among people who visit their GP, but the roles of primary care are relatively unresearched, although there's becoming more in the last few years. And given the prevalence of social factors in self-harm, so for example, things like job loss, unemployment, access to housing, there's a strong basis for social services-based or integrated approaches to suicide prevention. So this project consisted of 3 phases. I'm just going to be talking about the first 2 phases. The third phase is still sort of underway. For the first phase, I looked at evidence for the use of social services following self-harm, and I then looked at care gaps in people seeking help from the emergency department following self-harm. And throughout the project, I worked with 4 public contributors. They were involved in lots of different stages, but key to their involvement was developing measures of mental health treatment needs and social needs. Some of them have also been involved in presentations of this work. And the contributors are based in the Greater Manchester Patient Safety Research Collaboration, part of the Expert Lived Experience panel. And as part of this, we used agreed ways of working together, such as we prioritised well-being, we used safety plans and flexible ways of working. And if anyone is interested to know more about this, the approaches have been set out in a toolkit that was co-developed with researchers and public contributors. So this QR code will take you to the organiser version. There's also a public contributor version that are available to download. So for the first part of the project, I aimed to review the evidence for the use of referrals to social services among people seeking help following self-harm. And to do this, I used a systematic review with narrative synthesis design. I worked with experts in social care research to design research firms to capture the populations and the outcomes that we were interested in. We included both peer-reviewed academic research and grey literature of people of any age who were in contact with health services following self-harm, both primary and secondary care. And outcomes were either referrals to or the use of social services. So that can include local authority, social services, social workers, occupational therapists, and support with housing and welfare benefits. So just to an overview of this, so several thousand records were identified, but in the end we only included 10 studies. And this was the main reason was because most of the studies didn't include social services as an outcome. They focused more on mental health services. So yeah, 10 reports of 7 studies. They were generally moderate to high quality. They were all based in EDs, so there were no studies based in primary care, and most were based in the UK. One was also partly based in Australia and one was based in Ireland. So the rates of referrals were generally quite low, around 1 to 4% were referred to social services after self-harm. But in terms of actual use of social services, around 1 in 5 were found to have used social services. But this was limited to 1 study. And perhaps unsurprisingly, the referral rates were higher when social workers were involved in psychosocial assessments after self-harm. So in general, few patients are referred to social services after self-harm, but one potential mechanism for improving links between social services and health services is involving social workers in conducting psychosocial assessments. When we looked at rates of actual contact rather than simply referrals, we found that rates were considerably higher, so about 1 in 5, and much higher than in the general population. But as I said, this is limited to evidence from emergency departments. So I guess in conclusion to that study, we think that social services based or linked integrated approaches are important but potentially underused as a mechanism for addressing suicides in people who've harmed themselves. So this paper was published open access, so is freely available to read, and you can access it here. I'm just going to move on now to the second study. So this was carried out as part of phase 2 of the project. So just to self-harm, it's common for people who've self-harmed, as we've said, to face a range of social, economic adversities, and they kind of are interlinked with and can exacerbate mental health problems, but are not always addressed. And for this reason, NICE guidance recommends joint approaches between social care agencies, healthcare professionals, and community organisations. And the latest suicide prevention strategy, launched in 2023, also highlights the pivotal role of community services in suicide prevention. And in terms of care gaps, mental health care gaps more broadly are excellent. So just as an example, depression as an example, around 1 in 5 people with depression have received adequate treatment for depression, and this is in high income countries. In low income countries, it's even lower. So as few as 1 in 27 people received adequate treatment for their depression. There's so far been no examination until now of care gaps in self-harm. There have been some studies of rates of different types of management following self-harm. So rates of psychosocial assessment and referrals. As part of my PhD, I examined proportions of patients presenting to the ED who received these 4 main types of care. So we found that 58% of people received a psychosocial assessment by a mental health specialist. This is recommended care, so should be closer to 100%. But for various reasons to do with organisational factors, patient factors, this proportion is fairly consistently around 58%. So this work involved adjusting for confounders that were linked to receiving treatment, such as method of harm, but these factors don't always correspond to need for care. So another study shown here, this one based in primary care, shows primary care contact for self-harm and percentage of patients referred to mental health services within a year, stratified by deprivation quintile. So you can see quite a stark finding here so there's an inverse relationship between referral likelihood and deprivation likelihood, with the people in the most deprived quintile the least likely to be referred following self-harm. This is area-based. So I wanted to know more about the individual characteristics that are associated with poor care. So to do this, I used the Manchester Self-Harm Project, which is a cohort study based obviously in Manchester, and it uses a sort of two-phase approach. So basic information is extracted automatically from ED records, and then more detailed information, for example, clinical history, circumstances of the self-harm, is coded by researchers from the psychosocial assessments. In terms of aftercare arrangements, I categorised outcomes of this study into referral to mental health services, so things like outpatient, crisis care, urgent care services, and drug and alcohol services. Also referral to social services, referrals to VCSE, and referral back to the patient's GP. And individuals could see more than one of these in the same episode of self-harm. So first we simply looked at proportions of patients referred to the various types of services. And as you can see here, there was some overlap. But overall, 61% were referred to their GP. And amongst these, 20% had no new or current mental health referral. 37% were referred to mental health services, and 13% were referred to social or VCSE services. But did these referrals reflect the needs of patients? So we worked with clinical experts and people experiencing self-harm to co-produce indicators of mental health treatment needs and look at evidence of significant social problems. Based on the data that was available in the cohort, which are the list shown here, we were able to inform the measures of need for care. We then looked at who had evidence of mental health needs but didn't have a new or current referral to mental health services, and looked at differences between groups. And this allowed us to estimate where the care gaps were greatest. And we adjusted the relative risks for organisational factors that would be linked with likelihood of referral, but not necessarily to mental health or social need. So we adjusted for hour of presentation, which hospital they attended, the role of the person who's assessing them, and method of harm. I'll just summarise that table because it's quite long. So overall, around 30% of patients who were identified as having mental health needs had no or new referral to mental health. And these proportions of non-referral were higher for men, younger people, and people from South Asian and Chinese ethnic groups. We also found higher rates of non-referral among people living in more deprived areas. And within the group who had a mental health diagnosis, people with alcohol and substance misuse disorders had higher non-referral rates compared to those with other disorders. For example, 42% of those with substance misuse were not referred. And we found a similar finding for people with anxiety or trauma-related disorders. 34% were not referred. And in terms of diagnoses that were related to smaller mental health care gaps, we found that people with a diagnosis of personality disorder and eating disorder had greater levels of current input health services. Obviously, we don't know the quality or the nature of that input, but we did find that care gaps were smaller, suggesting they were maybe less reliant on their GP for care. So we did the same for social and voluntary services, so who had evidence of significant social needs but did not have a current or new referral. Again, I'll summarise that. So among people who had considerable social needs, 80% had no new referrals to relevant services, and 23% also had no active or new referral to services. And proportions of those with no new referral were higher for men. Again, people aged 45 to 64 and those who were unemployed. And with the exception of anxiety and trauma-related disorders, individuals with a mental health diagnosis who also had social needs had higher rates of non-referral compared to those with no diagnosis recorded. And this was especially high among people with substance misuse disorders. 88% were not referred. So I mentioned before that people with a diagnosis of personality disorder and eating disorder were perhaps better linked in with mental health services, but they were also more likely to be experiencing significant social problems with no evidence of input from social services or the voluntary sector. So just to give an idea of some of the strengths and limitations here. So it's the first study to examine care gaps in a population who've harmed themselves. We previously had some understanding about which groups were more or less likely to receive which types of care, but we were missing an overview, sort of a comprehensive understanding of the mental health and social needs of people along with their subsequent management. Another strength of the study is that the measures we used to estimate mental health needs and social needs were co-developed with patients and clinicians, including there were some limitations. So the measures, although they were co-developed, they weren't based on a validated risk set or scale. They were also limited to the information that was available in the psychosocial assessment. So it really depended on what the discussion with the assessor included. And again, not everyone received an assessment. In fact, people who were less likely to receive an assessment had, including substance misuse, being male. So I guess in terms of the consequences of this, we may have underestimated the care gaps. So that many health sort of more social and community-based services do address both mental health conditions. So it's quite difficult to separate out which services are addressing which things when considering this. So overall, we found substantial care gaps among people presenting to self-harm, to hospital following self-harm. 30% of those with identified need not referred to mental health services. And there were particularly large gaps for people with social needs. And one of the main concerns is that the care gaps we found were particularly high among some groups known to be at increased risk of suicide. For example, men, those at middle age, unemployed people, and those with a substance misuse disorder. We found that there was evidence of inadequate understanding of the needs of ethnic minority groups following self-harm. So we found particularly large gaps in some groups. And one of the recommended ways to address this is to make sure that when delivering training and support, and when designing interventions for people from these groups, is to make sure that any support is co-designed and that it is accessible and meets the needs of this group. We also found that while some diagnoses were associated with smaller mental health care gaps, for example, personality disorders and eating disorders, there was also evidence of unmet social need for these people. So this might reflect the severity of illness and the stigma associated with these diagnoses. On the other hand, people with alcohol and substance misuse had greater care gaps for both their mental and their social needs. In particular, people with diagnosed anxiety disorders were more likely to be relying on a GP for ongoing care rather than access to mental health services. And in terms of the social services and VCSE services, the role in self-harm care is still only recently being prioritised in suicide prevention policy. And research has shown that many people, perhaps those with negative experiences in the past of health services, do prefer to get support from places not connected to health services, especially mental health services. So such as peer support groups, online forums, and this needs to be understood and accounted for when designing aftercare. And finally, just thinking back to the slide where we saw that inverse association between rates of referrals to mental health services and area level deprivation. In this study, we didn't find low rates of referral from people from areas of high deprivation, but we did find that the gap between mental health needs and likelihood of referral was greater for people living in the most deprived areas. So in other words, the mental health care gap was greater for people in the more deprived areas who sought help for self-harm. That's me. So if anyone's wanting to read any more about any of those studies, they're both papers are now published and they're both open access. So feel free to have a look at those. And I think we're going to have some discussion and questions, so I'll stop sharing.
Thank you so much, Sarah. I think that was fascinating. I'm sure everybody else will agree. I don't know if anybody's got any particular questions for Sarah at all. Oh, Amy's leaving. Thank you, Amy.
Thanks, Amy.
Shall I kick things off then? I've got a couple of questions. I wondered, can you link healthcare data to social care data?
Yeah, that's a really interesting question. I definitely, at the time of doing the study, it was something that I was really keen to do, and unfortunately wasn't able to do at the time. It's now becoming possible. So I was presenting this work earlier this week and talking to someone who is actually doing that. And it's local. It's not national. It's only currently you're only able to do it at a local level, but it's definitely something that would give us a better picture of the services that people are using after self-harm. And I think looking forward, it's perhaps going to become more common for these data linkages to be available.
And the other thing I was wondering, did you look at interventions between the groups? For example, maybe ethnicity and area level deprivation?
We looked at, so in terms of ethnicity, we were fairly limited. You'll see I mentioned some quite broad groups. So we looked at South Asian groups, Black groups, and Chinese groups. But obviously, there's within those broad groups, there's a lot of different experiences and also different specific ethnic groups contained within those broad groupings. So I think perhaps looking together at deprivation level and ethnic group would give us more of a idea of which groups are experiencing additional deprivation, looking at the intersections there. I think that would be useful to do. I think one of the areas we're looking at in future work is to use more national data, because I think if you're wanting to look at ethnic group in a lot of detail, you would need national data, just partly because of the numbers involved. The numbers can get quite low. I think it's definitely something that would help our understanding if we could do that.
Yeah, another future project maybe.
Yeah.
Yeah. Has anybody else got any questions at all for Sarah? Oh, Magdalena.
Thank you, Sarah. It was really interesting. Thanks for sharing your research. I had a question that's obviously self-serving, because I'm interested in learning disabilities and research with people with learning disabilities. Was that a factor at all? Have you come across any data and information in your research that would relate specifically to people with learning disabilities, and maybe autistic people as well? And if not, then is it because you were not looking at it or not looking for it? Yeah, any thoughts on that would be great. Thank you.
Thank you. Yeah, we did look at, so we actually, again, because of the numbers, we actually linked together people with a learning disability and people with a diagnosis of autism, which may not have been the right decision. It may have been the right decision. So it was still a very small group, actually. We found, I was looking at this study again this morning. So we actually found that group were fairly well linked in terms of their mental health. So the care gaps were not so big. But when it came to social needs, they were not being met as well. So the gap there was larger than for some of the other diagnoses. There was one of those things is when you've got so many groups that you're looking at, you kind of it's hard to cover them all. But if you have a look maybe at the paper, there's a little bit more detail there. I'd be happy to talk to you as well if you have any questions afterwards. Just drop me a line. But yeah, I think generally I would summarize by saying that there was a larger gap in terms of their social needs and being linked with either social services or voluntary services to meet those needs.
Lovely.
Thank you. That's very helpful.
Has anybody else got any questions at all? Tyler?
Hiya. That was a really good presentation. I really enjoyed that. I was just wondering if you looked at the differences between people with maybe alcohol and drug use who are presenting with different substances, and if you identified any difference between those types of groups.
Thank you. Yeah, we did. So we use quite broad groupings because there's just so much potentially that you could look at. We split the groups by alcohol use, substance use, and then both alcohol and substance misuse. And we found, so yeah, the social need gap was higher for all of those. In terms of the mental health, I mean, they were better linked in with mental health services than people with no diagnosis at all, but not so well compared to some of the other diagnoses. I think there's just still a lot of potentially a stigma among the people doing the assessments, but also perhaps in terms of the follow-up not being active enough for those groups. So it's hard to tell from this data, but I think and again, it's an area for future research. I think it's very difficult, isn't it? Because you're kind of limited by, if you're referring someone to a service. I mean, I think particularly with this group, how confident can you be that the service will actively follow up with them and that they'll actually be able to contact services?
But whether a referral will actually be accepted because of the alcohol use, was that a
factor?
That's
that. Yeah, that's that.
Yeah. Well, thank you. That's a really good answer. Thank you.
Thank you.
Is there anybody else? I can't see any more hands, Sarah, so I think that might be it. So thank you so much for the seminar today. It's been absolutely fascinating. And we look forward to seeing people at future seminars.
Thanks, Claire.
Lovely. Thank you, Sarah.
Thanks. Nice to see you all.
Take care, everyone.